So I'm going to give my biased opinions and rants about EP testing, just to give you an idea of what it is that we do when we're screwing around down there and everybody else is falling asleep. And a little bit about ablation, some of the stuff we can do, some of the stuff we can't do, just so you've got an idea of what EP stuff in the lab is all about. And let's see, no, that doesn't work. How about this one? Ooh, that worked pretty well. This is just the, let's see if there's a, is that like a mousy thing or? Please tell me I don't need to use two hands. Oh my God. All right. Well, there we go. Ooh, it sort of bounces around. I just put this up as a quick reminder of our electrical system as we know it. Sinus node, where everything starts, the AV node that conducts from atrium to ventricle, and then the His-Purkinje system, which is what's responsible for getting the ventricles to contract nice and quick and smooth. So what the hell is, and this, it is not Gene Simmons. No. How old are you, 12? Or how old am I, like 100? Okay, so EP studies, what can we do? So we can measure basics of conduction systems, so AV node, infranodal conduction, induction of tachycardias, ablation of tachycardias, not a whole lot for bradycardia. So I'm going to go briefly over indications for EP testing because I think there's a lot of confusion about what it might or might not be useful for. It is good for diagnosing or ablating documented or highly suspected arrhythmia. So sometimes we'll have people who come in and say, yeah, I bend over, my heart goes 400 miles an hour, I stand up, it goes away. So those are the kind of people who we'll sometimes study without. But in general, our preference is to have a documented tachycardia if we can all find it, not rumors so much. Unexplained syncope in patients suspected of having an arrhythmia. And unexplained syncope in a patient with substrate for VT. Unexplained syncope is kind of a, it's sort of a nebulous one, and unfortunately, EP testing as we do it is really only specific for picking up tachycardia causes and sort of soft indications for bradycardia arrhythmias. And I'll get to that in a sec, but it's really not helpful for vasovagal syncope, for the nebulous symptoms, for I felt a skip, that kind of stuff we're really not very helpful for. This is just going to get so confusing with these two things. So may be helpful in ischemic cardiomyopathy and risk stratification. There's some debate about that, but patients who have low EF and coronary disease, there were all sorts of studies done 10, 15 years ago looking at whether inducibility was a marker for higher risk for sudden death. That was, I think, more popular, if you will, when defibrillators were a bigger deal to put in. Now we kind of put them in anybody who's got a low EF and slips on a banana peel. So we don't use them quite as much anymore, but they do have some limited utility. Brugada syndrome is a congenital channel-related thing which may or may not be useful. Syncope and suspected intermittent heart block or sinus node dysfunction. This is kind of a maybe. We get a lot of these people who have a left bundle and a first degree and a dizzy spell, or their sinus rate is 50 and they said they passed out, this kind of stuff. We can do some limited testing on that. The problem is that the sensitivity and specificity for sinus node dysfunction is not very good. You get a lot of indeterminate results and you don't know what the heck to do with it. So this is not necessarily our favorite, but we can, under certain circumstances, do that. Not helpful. Syncope and non-ischemic cardiomyopathy, by and large, non-ischemics, if they've got a low EF, we put a defibrillator in, so there's very little reason to do an EP study on them. The tests are not very specific and they're not very sensitive. If we try hard enough, we can put anybody into VF. So if you bring somebody to the lab with a low ejection fraction and we tickle them hard enough, sure, we get VF. What are we going to do with that? Well, we're going to put in the defibrillator. We're going to put in anyway. So we don't use it a lot for that. Syncope and a normal heart also, not very helpful. There's not a substrate there in general for arrhythmia, so we're not going to pick up very much. Documented VT unless ablation planned. If you know somebody has VT, it's not terribly helpful for us to bring them down and see if we can induce it. We don't do it for, it's not helpful for programming defibrillators, any of that. So that's not a very helpful use. Definitely not helpful. Routine after cardiac arrest. We do get a fair number of people sent to us for EP testing after cardiac arrest, and it really almost never tells us what to do. If you have somebody who's VF'd in the field and you do their workup and you check their coronaries and you check their QT interval and all that kind of stuff, and we bring them to the lab, if we can't induce them, are we going to say, well, probably never going to happen again? No. If we can induce them, we'll say, well, we knew that because you had a cardiac arrest. So this is another one of those cases where it doesn't generally change what we're going to do with the patient, and so we don't generally recommend this as a routine part of post-arrest evaluation. Documented symptomatic heart block. Again, they've got symptomatic heart block. What do you care if I tell you their HV interval is long? It doesn't matter. It doesn't change what we do. Drug-guided therapy was one of the initial uses of EP testing. We don't really do it that way anymore. Again, not very predictive. So you can put somebody on a drug and take them to the lab, and they may be inducible and they may not. It doesn't tell you necessarily whether their drug is going to work in the field. Ectopy or asymptomatic SVT, no reason to do it. Definitely not helpful. The weak and dizzies. Oh God, no. It will never pick up anything, and they'll get weak and dizzy when they get the IV. Autonomic dysfunction, that's not what we test for. We get, I'm going to have an aside on tilt table tests, which I can tell you EPs hate, because the reality is it's very uncommon that you can get anything from a tilt table that you couldn't get from history and orthostatics in the office. It's not a very sensitive test. It's not a very specific test. So when we get referrals for tilt table test or EP testing for autonomic dysfunction, that's not what we're going to do. There are people who study autonomic dysfunction who wire them up with EMGs and all sorts of other things and use the tilt table. That's kind of a different group. That tends to be the neurologists and folks. So it's not a service we offer, just so you know. And asymptomatic conduction system disease. So left bundle and first degree block. Unless they're symptomatic, we don't do anything. There's no reason for an EP study. Where, how long? Conventionally done under fluoro, although we're doing a lot more now with 3D mapping and have minimized fluoro exposure significantly. It's generally done from femoral vessels, 3 to 5 sheaths. Some places still use subclavian access. We don't tend to do that, but sometimes that's necessary. Sedation with Versed, fentanyl, or propofol, and rarely general anesthesia. The sedation thing's kind of funny because it turns out that there are some arrhythmias that go away with sedation. So some atrial tachycardias, you give them a little Versed and they don't care about a thing, and there is nothing on earth that's going to make them inducible. So those are cases where we'll use propofol because you can kind of wake them up, get them to go, put them back to sleep when they start to annoy you, wake them back up if you need to. It works great. Case time, usually 1 to 4 hours. Sometimes it drags on a lot longer than that, as anybody who works in the EP lab can tell you. But we try not to do that. In recovery, usually most of the procedures we do are outpatient, so 3 to 6 hours flat and they go home. We'll keep them overnight if there's transeptal puncture or we're worried about some other reason. But most of this stuff is all outpatient. This is the Swedish EP lab. No, actually, this is kind of what it looks like, with a bunch of monitors and machines that go ping and all that kind of thing. So I'm going to go over sort of the 3 components, if you will, of EP testing and ablation, and it's kind of I made this loop because it's not always. It's kind of like separating surgery from suturing. They kind of all work together, but. we'll go over the diagnosis, mapping, and ablation, and the loop that it turns in. So here's sort of basic catheters in the heart. This one is this working? There it goes. So this is a coronary sinus catheter that in this case is brought down from above the subclavian. We don't necessarily do that, but that's one way to get it in there. This catheter is placed on the His bundle. This one's down in the ventricle. This is an ablator down there. They're screwing around doing something. This one's up in the high right atrium. So this is sort of a typical setup for us. I'm not going to spend much time on this other than to explain to you why we talk about milliseconds instead of heart rate, because I think this annoys people, but there's a reason we do it. When you think about a tachycardia as being 200 beats a minute, that's fine if you're in a sustained rhythm, but when we're looking at these things, we're looking at how long it takes for it to get from ventricle to atrium, or atrium to ventricle, or atrium to His, and so it's much more helpful for us to think of it in terms of milliseconds. So 200 beats a minute is 300 milliseconds. And so all the numbers that you'll see as I go on are that way. It's kind of like describing how far it is to somewhere in miles per hour. It just doesn't make sense. So that's where we do that. And we've got this sort of system of describing what's pacing and what's not. So S1s are what we call regular pacing intervals, and if we put in PACs or PVCs, those are S2, and that's our sort of nomenclature for describing to one another what it is. So we may say, okay, throw in S2 in the atrium, and that tells us that we're giving a series of pacing stimuli and then a premature beat. So first part of what we do if we've got somebody down in the lab with a tachycardia, and I'm going to sort of use supraventricular as the model just because it's a little more straightforward in terms of description, is get basic intervals. So here's our EKG. This is what we would record with a catheter in the high right atrium, so this corresponds to the P wave there. This is what you'd see if you've got your catheter on the His bundle. So here's there it goes. So that's atrium. That's His bundle recording. So as it comes down the His Purkinje system, and this is the ventricle, and here's a catheter in the ventricle, and this would correspond obviously to the QRS. So these basic kind of numbers tell us what the AV node looks like and what the conduction system below, and will give us a hint about what we may be looking for. We've got a series of basic intervals. So what's the sinus rate? Sinus cycle length, again, this is our sort of inverse bass-ackwards way of looking at heart rate. The AH interval tells us about the AV node. HV interval about conduction below the node, the His Purkinje system. Sinus node recovery time we don't do often. It's an assessment of the sinus node, but it's kind of a squishy one. AV block cycle length, so at what heart rate does a patient start to Wenckebach? If they have Wenckebach at a cycle length of 1,000 milliseconds, so a heart rate of 60, that tells you that there's something, either they're on a drug or something else that's slowing their conduction, or maybe they've just got a weak conduction system, so that's good to know. VA block cycle length, so how well can they conduct backwards? If you know that somebody has no electrical conduction retrograde, so from ventricle to atrium, then that excludes a bunch of tachycardias. We know it's not something that involves an accessory pathway, for instance, or whatever. And the AV node refractory period. So what does the AV node do when you put in PACs, PVCs? So I thought the way I would kind of go through these three is to use AV node reentry as kind of the prototype for how we make a diagnosis. Flutter is the way we map, because it's kind of a straightforward, easy to visualize thing. And then Wolff-Parkinson-White syndrome, so accessory pathways for ablation, again, because the approach to ablating it is fairly straightforward. Arrhythmia diagnosis, history and exam. The history thing, particularly for syncope and oftentimes for SVT, is really important. You can tell a lot if a patient passes out suddenly or if they start to feel crappy and nauseated. If they tell you that their tachycardia starts When they bend over or cough, that suggests AV node reentry or some reentrant thing. If it always happens with exercise, that's helpful because we know that maybe we want to put them on an isoprel or adrenaline or epi or whatever to get it to go. So those things are useful. Rhythm strips are very helpful for us if we get a patient referred for tachycardia. Sometimes what is thought to be tachycardia isn't, so it may actually be sinus rhythm at 170 beats per minute, and we want to know that that's what we're looking for. We get a lot of sort of patient noted to have tachycardia on monitor during induction of anesthesia. Well, okay. I don't know what that is, you know. So rhythm strips are helpful. And then the baseline findings and activation and sequence and pacing maneuvers we'll go through. This is how an EP does a physical exam. Let's be honest, it's what we do. Looks good from the door. Let me see the rhythm strips. So pacing maneuvers, we've got burst pacing. So you just pace the heart fast and see what you can induce. So these are all S1s. Extra stimuli, PACs or PVCs. Dissociation, so can you separate atrium from ventricle or left atrium from right atrium? Sometimes you can do that. It's helpful in helping us make the diagnosis. And entrainment, which I'll go over briefly when we talk about mapping. So again, I'm going to use PSVT rather than VT as the prototype for ablation just because it's a little more common and straightforward. And we divide it kind of into two basic types, those that don't require the AV node and those that do. So don't require the AV node would be, I guess, AFib if you want to include it, because you can have AFib with complete heart block. You can have atrial tachycardia, which is just from the atrium with complete heart block. Atrial flutter, same thing. And those that do depend on the AV node. So AV node reentry or AV reciprocating tachycardia. So this would be an accessory pathway tachycardia. So that's sort of a basic way that we separate it and the way we start with our diagnostic maneuvers to figure out what we're dealing with. So here's AV node reentry, for instance. It circulates through the slow and fast pathway of the AV node. It makes a loop. So obviously, this is one of the AV node dependent arrhythmias. ORT is accessory pathway tachycardia. So it typically goes down the AV node and up the pathway. So obviously, it depends on conduction through the AV node. Atrial tachycardias is sort of the typical opposite. Start up here, and then it doesn't care whether your AV node's intact or not. So this is a non-AV node dependent arrhythmia. The other way we separate them when we're trying to work out what the mechanism is this sort of notion of long or short RP. In other words, how long is it between when the ventricle goes and when the atrium goes? And that, again, defines, it sort of separates it into two basic categories, and we'll look at that when we're trying to figure it out. So long RP is atrial tachycardia. There's no predictable association between the atrium and the ventricle, so that interval can be variable. Accessory pathways tend to be longer, and I'll show you a diagram of that. Atypical AV node reentry, and then short RPs, which is typical AV node reentry, because it goes down the slow pathway and up the fast. And then these two, again, I'm not going to get too much into this because you'll just all fall asleep. And the other thing that's actually pretty helpful is knowing the age distribution of these things. So the PEDS folks deal a lot more with accessory pathways, AVRT. As you get older, the number of people who start showing up with AV reentry or accessory pathway tachycardia starts to decline because they tend to show up when they're young. So AV node reentry is far and away the most common thing we see, and certainly the most common in, sort of middle-aged and early older age folks. Atrial tachycardias can occur anywhere, although when you get to older patients who have these little bursts of fast stuff, that's 9 times out of 10 atrial tachycardia. Patients with lung disease will get, multifocal atrial tachycardia. So again, kind of knowing what you might expect for a given age group is helpful before you go in. And this is just sort of our principle, and I'm not going to bore you with it other than to show you that this is unfortunately the way we think. So here's a typical SVT, narrow complex tachycardia, okay? And it turns out that this one was AV node reentry. And so here's a diagram of AV node reentry. Comes around the AV node, fast pathway, slow pathway. The atrium and the ventricle are kind of activated, if you will, in parallel, because everything comes around the node, so it shoots the atrium, shoots the ventricle at the same time. And so when we look at the intracardiacs, that's what we'll often see. So this is the good old AH jump. This is what tells us that somebody has dual pathways in their AV node, which is a sort of a requirement, if you will, for AV node reentry. So here is a short AH interval, so atrium, His bundle, ventricle, atrium, His bundle, ventricle. You put in a extra stimulus, and all of a sudden you can see here, or always pretend you can see, that the AH interval jumps out. So this is the difference between the fast pathway, short, slow pathway, long. So if we see this in somebody at baseline, we're doing our baseline intervals, this at least tells us that they've got the potential for AV node reentry. It doesn't mean that that's what their tachycardia is. They could have an atrial tach and dual AV nodes. They could have an accessory pathway and dual AV nodes, but we know that the substrate is there. And here's how the tachycardia might start. So all of a sudden you give a premature beat, it jumps to the slow pathway. You can see this long interval through the AV node. And then this is a short RP tachycardia because the interval between here, where the QRS starts, and the P wave, which is right there, is short, okay? So this is a classic, typical AV node reentry EKG or intracardiac, and we say, thank God we know what this one is. The other maneuver that I'm going to try vaguely coherently to explain is entrainment, because it's one of the key maneuvers we use in the lab to sort out AV node dependent from AV node independent arrhythmias. So again, AV node reentry is AV node dependent. It goes down one pathway, up the other. And if you get into that circuit by pacing the ventricle, so if you've got a rhythm that's going around here and down and up, and you pace the ventricle during the tachycardia, you can actually get yourself into that loop. When you stop pacing, you would expect that you quit pacing, it goes back up, it loops around the node, and comes back down. And so what we will see is our last pacing stimulus, the atrium, and then the ventricle. So a VAV response is what we look for. And this is the hallmark of an AV node dependent arrhythmia. So here it is in live action. So here we are. Here's somebody in tachycardia. We start pacing. Here's our last pacing interval. It goes up to the atrium. And because it's going down the slow, up the slow and down the fast, or up the fast and down the slow, if it's typical, up to the atrium, down to the ventricle, VAV. So that tells us it's something AV node dependent, and this happens to be AV node reentry, and we know that because this VA interval is short. So this is a short RP tachycardia. If you've got an AV node independent arrhythmia, like the atrial tachycardias or atrial flutter or something like that, we see the opposite. So you get into that circuit, you go up to the atrium, but the atrium is driving the rhythm. So you're going to have to get another atrial beat before you get the ventricle. So we see this VA, and then the next atrial tachycardia beat, and back down to the ventricle. So you can sort of see that what you've basically done here is dissociate what the ventricle is doing from what the atrium is doing. So it's, in effect, analogous to what happens if you give adenosine to somebody with an atrial tachycardia. You see it marching through. That's kind of what we're illustrating here, but with a pacing maneuver instead. The other thing that is helpful to us is how a tachycardia starts. So oftentimes, how it starts and how it stops is more important than what it looks like during the rhythm, especially if we can get rhythm strips from hospital or monitors or whatever, knowing how it stops is very useful because here, for instance, is AV node reentry. And remember, it's AV node dependent. So the last beat of this tachycardia was an atrial beat. If it was an atrial tachycardia, you would expect that it would go back down through the AV node and maybe it would stop. The fact that the last beat of this was in the atrium and then it stopped tells you that when it didn't conduct through the AV node, that made the tachycardia stop. So it's tachycardia dependent on the AV node. And in fact, if you see this on an EKG, you see somebody in a tachycardia and the last thing you see is a P wave and they go back to sinus, that's a good indication that it's an AV node dependent arrhythmia, so something reentrant. Okay, SpongeBob, thank you. So next step is mapping. So we've figured out what the tachycardia is. It's AV node reentry, it's WPW. The next question is, well, where the hell do we need to cook this thing? And we've got conventional mapping, which is recording from a bunch of sites with those multipolar catheters. So that's what we'll see when we get these things. This is sort of our conventional mapping tools. And then electroanatomic or 3D mapping, which is a whole lot more exciting and more colorful, and allows us really to reconstruct in 3 dimensions using color maps and isochronal maps what the whole ventricle or the whole atrium is doing at once. And I think I've got some pictures so you can see, but we've moved, we still do some conventional mapping and it's always part of everything we do. The number of tachycardias we now ablate with only this is pretty small because the other advantage of the 3D mapping is it allows us to minimize fluoro. We can see where our catheters are without X-ray. Activation and entrainment are sort of 2 of the techniques we use. So activation is what comes first, what comes second, what comes last. And entrainment, what happens if we get into that circuit? Does it start? Does it stop? Does it keep going? And then the learning while burning, it's just a reality. We'll think we know what the hell we've got, and we'll burn there and nothing happens. And you say, well, I thought that's what it was, but evidently it's not. Or I thought that's where the pathway was, but evidently it's not. And we do more of that than we'd like to confess. And if you ever read an EP report and there's a lot of hedging, it's because that's what we were doing. So mapping. So here's typical atrial flutter, and it's got that sawtooth pattern that we all recognize as atrial flutter. Okay. Now the circuit for atrial flutter, you probably know this, but I'll bore you with it anyway, is a loop, typically counterclockwise around the tricuspid valve. So it makes a loop like this. This is another non-node dependent. So it goes around at typically 300 beats a minute, let's say 200, 250 milliseconds, and comes down to the ventricle, and typically 2 to 1, which is where we get that 150, okay? So here would be sort of conventional mapping catheters that we might use to do that. So we'll put one here so we can pace the typically the ventricle or the atrium. Here's one that's wrapped around the tricuspid annulus, so it gives us activation at each of these points. Here's one coming from above in the coronary sinus. So the coronary sinus catheter we use to kind of tell us whether things are earlier in the right atrium or the left atrium. So atrial flutter, for instance, is a right atrial arrhythmia, so we'd expect that everything is going to be earlier here than out there. So here's a catheter kind of going into the coronary sinus. You can see a multipolar thing. And this is what it might look like on X-ray. So here is that catheter. This is sort of a slightly different kind, but again, wrapped around the tricuspid annulus. This one is out in the coronary sinus, and here's an ablator. And this would be, it's kind of hard for me to show this, but this would be what we would see with our catheter. So imagine here are our electrode pairs wrapping around the valve. This electrode pair here is going to be here. This one is there. Excuse me. And so forth. And if you look at this, this is kind of marching. This tells us it's going here to here to here, there to there to there. So this is our activation sequence mapping for atrial flutter. This would be the same thing in the other direction. So this would be clockwise flutter, and you would see this pair first, then that pair, then that pair, then that pair, just like that. So this is a conventional mapping of atrial flutter. This would be a three-dimensional static isochronal map of the same thing. So red is early, purple is late. This is down kind of by the coronary sinus ostium. This is the inferior vena cava, and you can see that colors get progressively later and later and later, and then here's where early meets late. So the latest thing meets the earliest, and this is what a three-dimensional map would look like of flutter. And this thing, let's see if this is going to work. Ha! The AV guy got this to go. This is amazing. So this is an activation sequence map of atrial flutter. So instead of this isochrones, you can see here is the wavefront coming up around the valve and down and back around. So this is a map that we could get if we recorded in 3 dimensions at multiple points, and we'll typically move the catheter around to get all this data, so it may take a fair number of minutes to get this, but this you can imagine it's kind of helpful for flutter, but it's really helpful for things like ventricular tachycardia, where the circuit may be anywhere, and it can be very hard to track down. It's very helpful for atrial tachycardias when we're trying to figure out where it's starting, because you can get all this data at once rather than sort of having to reconstruct in your head, was that first, was that last? And entrainment is, I showed you that with the AV node reentry, but it's another one of our sort of key tools at looking at how reentry works. If you've got, a lot of the tachycardias are a loop. So it's going around through the AV node, it's going down the AV node up an accessory pathway, it's going around a scar in the left atrium or around a scar in the ventricle from VT. And so being able to get into that circuit gives us some clues as to whether we're near the circuit or not. So for flutter, for instance, we can do the same thing. We can get into the flutter circuit, pace a little bit faster, and make sure that when we stop, the sequence is the same. So we've gotten into it. It comes right back around at the same time, the same cycle length as the tachycardia, and keeps going. And we can get fooled. Flutter is one of those things where usually it just is what it is. Let me go back to here. It's just making a loop like this, and you look at the EKG and you say, that's flutter, what the hell, I'm going to avoid the isthmus, get out of here. In patients who have had prior surgery, prior ablation, sometimes what appears to be is not at all. So if someone has had, for instance, prior ablation for flutter, they can develop a tachycardia that may come from the left atrium. It comes in here, it loops around to there because it can't get through here because of prior ablation, and that focal tachycardia is going to look exactly like atrial flutter. And we've had these people. We bring them back. We think they've got recurrent flutter after an ablation. This line is still blocked, and it turns out it's a left atrial tachycardia that's doing this. So that's why, even for something that seems relatively obvious like flutter, these entrainment maneuvers can still be pretty helpful. So you could see exactly the same pattern in the right atrium if you had a tachycardia over here that came in and looped around. The only difference in the map would be that instead of seeing it come through here, like you do in this map, it would stop. And it would go around and stop, and around and stop, but your EKG would look exactly the same. And so here is where our catheters would be for isthmus ablation, for instance. And the simulator thing actually goes to this, so I'm not going to spend too much time on that. And then ablation. So most of our ablations now are done with radiofrequency. You can use cryo. We don't use it quite as much. The peds guys use it a lot, but we don't for adults so much. the media seems to be infatuated with this idea that we've got like a laser. We almost never use lasers. I mean, I'm using one now, but it's not. We don't have high-powered lasers for this. It's radio frequency, and it's not a hot poker. So the RF catheter is not. It's not like branding a cow. You're delivering current, so there's an indifferent ground patch. It's more like electrocautery. There's an indifferent ground patch, and it delivers. We deliver radio frequency between the tip of our catheter and the ground, and what happens is that current causes local heating in the tissue here. So it agitates the water molecules and everything else and creates a virtual heating source. So, because we want to control this area, we don't, if we're just going for a small area, we don't want to cook the whole damn ventricle. And so the size of this catheter and whether it's cooled allows us to titrate this lesion size fairly closely. So if your catheter flops somewhere else and you don't have RF on, you're not going to burn a hole there or something. This is what a conventional manually steered catheter is, and we've got some up here. This happens to be a different brand, but the idea is here's the tip. This little thing allows us to steer it left or right, and there's a locking lever. Taylor, you want to hold that up? Wave it around, pass it around. Try not to hurt yourself. So that's what an ablation catheter looks like. We also have a system now that uses external magnets. It's called the stereotaxis system. The difference being that the catheters are very floppy. They're like a piece of wet spaghetti, and they're held in place and manipulated by magnets on the outside. So we've been using this a fair amount too, but it's the same basic principle. It just allows me to sit in the back and eat a Pop-Tart instead of being in the lab with the patient and the anesthesiologist and all the annoying people circulating around. Hi, lovely people. Oh, were they? Oh. So I'm going to use WPW as the prototype for ablation. Again, in WPW, you've got a short circuit that bypasses the AV node, and it crosses usually, more often, the mitral valve, sometimes the tricuspid valve, is a short circuit around that skeleton. So what we obviously need to do when we're ablating it is figure out where it crosses the mitral valve, for instance, and get our catheter there. So here's a typical WPW patient, and you've got the delta wave there, and you can see it pretty clearly here, and you can see it pretty clearly there. And when we have catheters in the heart, so back to our basic intervals, this is what we might see. So here's so P wave, His bundle, ventricle, and you'll notice here's the slurring of the delta wave. And because this is short-circuiting the AV node, this interval here from His bundle to ventricle is going to be very short. In fact, it may even be negative because the ventricle, the onset of the QRS, has already begun before things even get to the AV node. So this is what we would see at basic intervals in somebody with WPW. We're seeing this thing beating that thing, the pathway beating the AV node. And this is what it looks like during tachycardia. So this left bundle and narrow is illustrating something different, but it just happened to be a good drawing of it. But you can see here's atrium. This is our mapping catheter. This is the coronary sinus. And so since it's going down the AV node and back up the pathway, you're going to see this part, so distal coronary sinus, so far out on the left atrium, come first because it's coming down the node, it's scooting way around to the left side and coming back up. So this would be a fairly typical pattern for a left-sided accessory pathway. This is what we would see. And what we're going to want to do when we want to ablate is figure out where these two things are the closest. Because if we know where the ventricle and the atrium are most tightly matched, that's obviously where the thing is crossing the skeleton, so crossing the valve annulus. So this is where we're going to want to look. So we will put our catheters, map around the mitral valve. And sure enough, if you get to a good spot, you'll see that the signal from the atrium and the signal from the ventricle are almost right on top of one another. So it means we're short-circuiting right around. And this would be a nice place. If we saw this, we'd be pleased. Here again, this is the place where they're the shortest. Sometimes you even get lucky and you can actually see the potential that's generated as electricity comes down that accessory pathway. We don't often get that lucky, but that's what this arrow is pointing to. So just hallucinate with me on that. And you turn on your not hot poker, and boom, there goes the delta wave. So we've eliminated that short circuit. And voila, everyone's happy. So ablatable, just to recap, AV node, supraventricular arrhythmia, so AV node reentry is a slow pathway thing. Great. Accessory pathway tachycardias, atrial tachycardias, so things coming just from the atrium we can ablate if we can get them to go, and that can sometimes be a challenge because they can oftentimes be non-inducible, especially for those short little bursts that older folks get. Typical flutter, fine. AFib, I say some because some people are just, that horse has left the barn, it's not worth trying. Atypical flutters, so things after maze surgery, we love to see those post-surgical maze patients come in with flutters. Oh yeah. Monomorphic ventricular tachycardia, PVCs, if people have a lot of them, we can do that. What we don't, won't, can't, or would rather not. There is a collection of those. So sinus tachycardia, colossal pain in the ass. There was some sort of, in fact, many years ago, Daryl, when I was training, people would try to ablate sinus tachycardia. The problem is that the sinus node is on the outside of the atrium, and so trying to cook that thing from the inside is difficult, number one. Number two, the sinus node is big, so it's not one little spot. So you oftentimes, even if you can get to the outside, you can't cook the whole damn thing. And the sinus node, because it was reasonably well designed, is very durable. So it's very hard to get rid of it, and it comes back. And even more frustrating with sinus tachycardia patients, these inappropriate sinus tach people, is you can ablate them and you can get their sinus rate down and they still have palpitations. They still complain. So we don't like to do this. Polymorphic VT, the circuit is not predictable. VF, we don't ablate. The reason I've got this asterisk is under rare circumstances, and I do mean very rare, there will be patients who go into VF, and every time they go into VF, it's a PVC from the same spot. You'll see that it's the same coupling interval, it's the same morphology, and under those circumstances, and oftentimes it's from the His-Purkinje system, if you can find that one magical spot and you can somehow induce it in the lab, you can ablate it. And these are more case reports than anything else. PACs, no. MAT, same thing. It's coming from a bunch of places. It's like whack-a-mole. It just doesn't work. Now what am I doing wrong? Did I burn out the battery? There we go. I wanted to give equal time to non-invasive approaches. This is like a chiropractic approach to managing SVT. I don't know exactly how you manipulate the fourth rib, but they terminated PSVT with that. And am I doing some? My favorite? Yes. I don't think, we tell people a lot about vagal maneuvers. I have never, ever told somebody to do this. And I think if they did it, I would not want to see them back in clinic.